You know that feeling. You're looking at this huge stack of information, maybe articles, notes, all about something complex like, well, vascular health.
Oh, absolutely. It's like, where do you even start? How do you pull out what really matters?
Exactly. Can feel a bit overwhelming. So that's what we're doing here today. Welcome to a deep dive.
Yeah, we've got this collection of source material from a listener who wants to really understand vascular health better.
That's right. We're going to unpack atherosclerosis, what it actually is, what fuels it, those big risk factors like smoking, diabetes, blood fats, high blood pressure.
Dyslipidemia and hypertension, yeah.
Right. And then we'll really zero in on peripheral artery disease, or PAD, and how it's managed.
And based on these sources, there's a surprisingly strong focus on just how powerful exercise can be in managing PAD.
So our mission today, we're going to guide you through this material, pull out the key insights, maybe some surprising facts, and the stuff you can actually use. Think of it as your shortcut.
Okay, let's dive in. So right off the bat, these sources stress something crucial. Atherosclerosis isn't just like one clogged pipe somewhere.
No, it's systemic.
Yeah.
That's the word they use, meaning it affects your whole circulatory system, legs, heart, brain, everywhere.
And the potential results of that, they're really serious. We're talking heart attacks, strokes.
Yeah, amputation, kidney failure, constant pain, and unfortunately even death. It's heavy stuff.
And the sources seem to focus heavily on PAD, Peripheral Artery Disease, as sort of a common signpost for this bigger systemic issue.
Right, millions have it, but what's striking is how often it goes, unrecognized or maybe undertreated.
Exactly. Even though it has a massive impact on how well people can function day to day and just their overall quality of life.
And here's a point that really jumped out at me from the material. It's actually quite alarming. Just having PAD is flagged as an independent risk factor for dying.
Independent, okay.
Yeah. Having PAD means you have something like a 3 to 10 times greater risk of a major cardiac event or death compared to someone without it.
Wow. That really hits home why understanding and managing this is so critical.
Absolutely. And it brings us to the root causes, or at least the major drivers. The sources hammer home these 4 big modifiable risk factors.
The ones we can potentially do something about.
Exactly. Smoking, diabetes, dyslipidemia. That's the blood fat issue.
Cholesterol, triglycerides, all that.
And hypertension, high blood pressure. These are the main targets.
Okay, so let's tackle them one by one. Starting with smoking. The sources use really strong language here.
Yeah. What do they say?
They call it the single most important modifiable risk factor for getting PAD and for making it worse.
The single most important. Okay, that's a big statement.
And the data points are stark. People who smoke get diagnosed with PAD a whole decade earlier.
A decade? Wow.
And that leg pain when walking, intermittent claudication, 3 times more common in smokers.
So why is it so bad for arteries? What's the mechanism?
Well, the sources list quite a few things. It messes with the endothelium, the lining of your blood vessels, so they don't relax properly.
Okay, that makes sense.
Carbon monoxide from smoke cuts down oxygen delivery. It makes your blood thicker, more prone to clotting, increases red cells, fibrinogen.
Like sludge, almost.
Kind of. Plus, chronic inflammation, you see higher C-reactive protein. Nicotine itself raises heart rate and blood pressure, injuring arteries.
And then there are free radicals from the smoke oxidizing your LDL cholesterol, making it stickier.
It's just, yeah, a multi-pronged attack on the vascular system.
But there's good news too, right? Quitting helps.
Hugely. The sources detail the benefits and also strategies for quitting. They mention the 5 A's for clinicians.
Ask, assess, advise.
Assist and arrange follow-up. Basically, a structured way to help patients quit.
And what kind of assistance works?
Well, medications definitely help. Nicotine replacement patches. Gum gets about a 16% quit rate at 1 year, according to this.
Okay.
A drug called bupropion does better, maybe around 30% success at a year.
Interesting. What about other support?
Telephone quit lines are highlighted. Apparently, people who use them quit at twice the rate.
Twice the rate. That's significant.
Yeah. Counseling, individual or group, also effective. Less so things like just self-help books, acupuncture, or filters based on this material.
So what really makes the difference for someone trying to quit?
Seems to boil down to making that firm decision, setting a quit date, having a plan, knowing what withdrawal might feel like, and having a maintenance strategy.
And for doctors dealing with PAD patients who smoke?
The advice needs to be consistent. Tell them to quit every single visit. That reinforcement is key.
Okay, let's shift gears to the second big one, diabetes. How does that play in?
The sources describe it as a massive accelerator. It speeds up atherosclerosis by 200% to 400%.
2 to 4 times faster. That's huge.
It is. and the specific risks. A fourfold increase in developing PAD or claudication.
4 times.
And maybe even more shocking, a sevenfold higher rate of amputations compared to non-diabetics.
7-fold. Gosh, what's the link? Is it just high blood sugar?
High blood sugar is part of it, yeah. Hemoglobin A1C, that long-term sugar measure, definitely predicts atherosclerosis risk.
Right.
But it's more complex. Insulin resistance plays a role, high insulin levels, and the high glucose itself directly harms the endothelium, makes vessels constrict more.
And the sources mention something called AGEs.
Ah, yes, advanced glycation end products. Basically, sugar molecules sticking to proteins and fats, making them, well, sticky and damaging.
How do they damage things?
They fuel the whole plaque process, stimulating inflammatory cells, making platelets stickier, increasing inflammation, trapping LDL, making vessels stiff. It's bad news.
Diabetics often have issues beyond the big arteries too, right?
Absolutely. The sources distinguish between that macrovascular disease, the atherosclerosis we're talking about, and microvascular disease.
Tiny blood vessels.
Exactly. Leading to things like kidney disease, nephropathy, which is a top cause of kidney failure, eye disease retinopathy, a top cause of blindness, and nerve damage neuropathy.
Nerve damage, especially in the feet, right? That's why foot care is so important.
Critically important. That loss of sensation combined with poor circulation is a recipe for serious problems, ulcers, infections, and ultimately amputation risk. The sources stress the need for regular foot screenings with that monofilament test.
So managing diabetes in this context, what's key?
Aggressive control of the other risk factors is paramount. So really tight control of blood pressure and lipids.
Okay. Specific drug mentions.
ACE inhibitors, or ARBs, are often preferred for blood pressure in diabetics because they protect the kidneys. Aspirin is usually recommended for prevention if you're over 40. Beta blockers after a heart attack. Metformin is typically the first-line drug for type 2.
Got it. Any other diabetic considerations mentioned?
Yeah, higher rates of sexual dysfunction, especially if they also have high blood pressure. And practical things like making sure you use the right size blood pressure cuff on someone who's overweight to get an accurate reading.
Okay, good points. Let's move to number 3, dyslipidemia, the blood fats issue.
Right. Basically, having unhealthy levels of cholesterol, high total, high LDL, bad cholesterol, high triglycerides, or low HDL, good cholesterol.
How do these fats cause problems?
Well, they travel in the blood in packages called lipoproteins. LDL is the main carrier that deposits cholesterol into the artery wall. It gets oxidized there, triggers inflammation, and builds plaque.
And HDL is the good guy.
HDL helps pull cholesterol out of the artery wall and takes it back to the liver. So higher HDL is protective. The sources also mention apolipoprotein B, or ApoB, might actually be a better predictor of risk than just LDL alone.
Interesting. What about triglycerides?
They're linked more to inflammation and clotting risk, and there's also lipoprotein A, which is an inherited risk factor some people have.
So how does this all lead to plaque?
The model described is usually some initial injury or dysfunction in the artery lining, then inflammation kicks in, then LDL cholesterol infiltrates, gets oxidized, eaten by immune cells, which become foam cells, the start of plaque. Eventually, a fibrous cap can form over it. High cholesterol also makes your blood more likely to clot.
Can this run in families, or is it always lifestyle?
Both. There are definitely inherited genetic forms, but it's often acquired, meaning it's caused or worsened by things like diabetes, low thyroid, obesity, alcohol, or even some meds like certain diuretics or beta blockers.
So how do we manage it? I know the thinking on targets has changed.
That's a huge point in these sources. The latest guidelines, like from the ACA, have moved away from treating to specific LDL or HDL numbers.
Right, no more target levels in the same way.
Exactly. The focus now is much more on identifying patient groups who clearly benefit from statin therapy.
Like who?
People who already have cardiovascular disease, those with really, really high LDL, diabetics over 40 with other risk factors, or people with a high calculated 10-year risk score.
And statins are the main tool.
They're the primary medication class. They work mainly by reducing cholesterol production in the liver and helping the liver pull more LDL out of the blood.
They have different strengths.
Yeah, they talk about high-intensity statins aiming for a 50% or more LDL reduction and moderate intensity, aiming for 30 to 50%. Specific statins fall into each category.
Do they do anything else besides lower LDL?
Yes, and this is important. They have other effects, pleiotropic effects, they call them. Anti-inflammatory, help stabilize existing plaque, improve blood vessel function, maybe reduce clotting.
So multiple benefits. Are the downsides? Side effects.
Muscle aches are the most commonly discussed one, sometimes severe, though that's rare. Risk is higher in older people or those with kidney or thyroid issues. Grapefruit juice can interact with some.
And didn't the sources mention an interaction with another common drug?
Yes, specifically atorvastatin, a very common statin potentially interfering with clopidogrel, an antiplatelet drug. That's something clinicians definitely need to be aware of if a patient is on both. Might need to choose a different statin.
What about other cholesterol drugs besides statins?
They're mentioned niacin, fibrates, others, but the sources basically say recent big studies haven't shown they add enough benefit for routine prevention to outweigh potential side effects, compared to just using statins effectively.
Which brings us back to
Lifestyle. It's
Yeah.
hammered home again and again. Lifestyle changes are the foundation. Even if you need medication, the diet, exercise, weight control, not smoking, that's all still crucial.
what kind of diet?
Heart-healthy basics, lower saturated and trans fats, more complex carbs, fruits, vegetables, less dietary cholesterol and sodium.
And exercise helps lipids how?
It's particularly good at raising the good HDL cholesterol and lowering triglycerides.
Are there groups who need special attention for lipids?
Yes. Diabetics often have a particularly risky type of small, dense LDL and need aggressive management. For women, especially postmenopause, high triglycerides are a really strong risk predictor. The elderly generally benefit from statins if they have vascular disease but need careful monitoring, and people with kidney disease also benefit from lipid lowering.
Okay, makes sense. Let's hit the fourth horseman. Hypertension, high blood pressure.
Right. Called a constant and independent risk factor and one of the big four driving atherosclerosis.
And it damages organs all over, right?
Absolutely. Heart disease, heart failure, stroke, PAD, kidney disease. The list goes on. It's a major cause of what they call target organ damage, or TOD.
And it's incredibly common.
Hugely prevalent worldwide, a leading chronic risk factor for death. And the sources note significant disparities. African Americans tend to develop it younger, have it more severely, and suffer worse outcomes like stroke and kidney failure.
Is there usually a cause or?
Mostly not. That's primary hypertension, the most common type. But sometimes there is an identifiable secondary cause, things like sleep apnea, kidney problems, thyroid issues. Even certain medications can cause it.
How's it diagnosed properly?
Not just one reading. It's based on the average of several readings, taken correctly over multiple visits. And a key part of the workup is looking for that target organ damage, checking the heart, kidneys, eyes, blood vessels.
And treatment, when do you start?
The JNC8 guidelines mentioned focus on treatment thresholds, specific blood pressure levels where starting medication is recommended based on age and other conditions.
But before meds.
Always lifestyle first. That's a constant refrain. Diet changes, weight loss, regular exercise, these are fundamental. Exercise is even called an effective adjunctive treatment alongside meds.
What are the target BP goals mentioned?
For people 60 and older, the goal cited is generally under 1490. For younger adults, 30-59, the diastolic goal is under 90, and systolic maybe under 140 based on expert opinion, though strong trial data was lacking for that specific systolic target.
And the go-to medications.
The evidence points strongly to four main classes for initial therapy: thiazide diuretics, calcium channel blockers, CCBs, AC inhibitors, ACEI, and angiotensin receptor blockers, ARBs.
Why those four?
They generally have similar positive outcomes in large trials, except maybe in heart failure, where diuretics often have an edge initially. Other classes like beta blockers didn't have the same level of evidence for starting therapy, or sometimes showed worse outcomes compared to these four in specific studies.
And you start treatment. One drug?
Yeah.
Two.
Often one drug if the pressure isn't super high, stage 1. A diuretic is a common first choice. But for higher pressures, stage 2, starting with 2 drugs from different classes is often recommended.
Why two?
Gets the pressure down faster and more effectively. The sources mention a 23% reduction in major cardiovascular events or death with initial combination therapy compared to starting with one drug and adding later.
Are there differences in which drug class to start based on the patient?
Yes. For non-Black patients, any of the 4 main classes are generally fine, but for Black patients, the recommendation is usually to start with a thiazide diuretic or a CCB.
Why is that?
One large trial showed a higher rate of stroke when starting with an ACE inhibitor in that population compared to a diuretic. And patients with chronic kidney disease should ideally be on an ACE inhibitor or an ARB because those drugs help protect kidney function.
What if the first drug or drugs don't work enough?
You increase the dose or add another drug after about a month. Max out doses before adding a third from a different recommended class. And a key point, Never combine an ACE inhibitor and an ARB.
Okay, never ACE plus ARB. Got it. What if even 3 drugs aren't enough?
That's called resistant hypertension. Need to look for reasons, maybe incorrect measurement, an underlying secondary cause, patient not taking meds, too much salt, interactions with other drugs. Renal denervation is mentioned as a newer potential approach for this.
So putting it all together for someone who already has vascular disease like PE?
If their risk is high, like having heart disease, generally any of the main antihypertensive classes can be used. The key is aggressive management to get the pressure down.
Especially if they have other conditions.
Exactly. Like diabetes, the risk is compounded. They benefit hugely from control and often need multiple drugs.
Oh.
The elderly need careful titration and monitoring and often have a slightly higher BP goal. And for African Americans, again, diuretics and CCBs are often preferred first-line choices due to evidence and prevalence patterns.
Bottom line. Controlling blood pressure helps the vessels and reduces the disease.
Definitely. Improves vessel structure and function, slows down the whole process.
Okay. So we've covered atherosclerosis, the big 4 risk factors driving it. Now let's pivot specifically to managing PPA itself. And the sources really highlight one thing here: exercise.
Yeah, the benefits are broad, reduces overall cardiovascular risk, improves fitness, insulin sensitivity, lipids, blood pressure, all that.
But for PAD patients with claudication, that leg pain.
That's where the effects are described as most impressive.
How impressive.
The numbers cited are pretty stunning. Average walking distance before pain starts increased by 179% with training.
Wow, almost tripled.
And distance to maximum pain increased by 122%.
That's life-changing for someone limited by leg pain.
Absolutely. And the sources explicitly state these improvements are often better than what's seen with medications or even surgical procedures for claudication.
Better than surgery.
For symptom improvement, yes. They mention the CLEVER study, which found supervised exercise outperformed stenting for improving walking distance in certain PAD patients.
That's a powerful finding, which leads to these structured programs.
Right, the Peripheral Artery Disease Rehabilitation Programs, or PRPs.
What's the goal of a PRP?
It's really about empowering patients to gain control over their disease, manage symptoms, avoid complications, and improve function. And crucially, it provides the support needed to make those really tough lifestyle changes.
What specific benefits does exercise within a PRP provide, according to the sources?
Improved walking ability, speed, distance, duration, less pain, better quality of life, and real biological changes. Blood vessels dilate better, more capillaries grow, muscles get better at using oxygen, endothelial function improves, inflammation markers go down, plus overall heart conditioning and risk factor reduction.
So how do these programs typically work? What are the phases?
They're often modeled after cardiac rehab. Phase I is usually inpatient, maybe right after a procedure like bypass or stenting.
What happens there?
Mostly education about the disease, risk factors, why lifestyle change is essential even after the procedure they aren't cured, and introducing the idea of joining the outpatient program.
Okay, then phase 2.
That's the main outpatient program. It involves detailed assessments, the core physical reconditioning, and ongoing education.
What kind of assessments?
Checking cardiac risk, often a treadmill test to measure their baseline walking distance and pain onset, assessing functional status, quality of life surveys, reviewing risk factors, and setting personal goals.
And the exercise part, the reconditioning.
That's called the cornerstone. It involves structured supervised sessions, maybe 3 times a week, 45, 60 minutes, often for 20 weeks or more.
What kind of exercise?
Here's a key point for claudication from the sources. Walking is the best exercise for improving the walking pain itself.
Oh, just walk.
The typical protocol is walk on a treadmill until they reach near maximal leg pain. Then, instead of stopping, they switch to other equipment that doesn't stress the calves as much, like an arm bike, stationary cycle, maybe rowing to keep their heart rate up and get continued aerobic benefit.
So walk to pain, then switch to keep going.
Exactly. It allows them to accumulate more exercise time, improves overall fitness, and prevents boredom. The goal is to build up to 35-40 minutes of aerobic activity per session.
What about exercising at home?
That's crucial too. The aim is a lifelong habit. So during phase 2, they work with the patient to develop a realistic home exercise plan, usually involving daily walking. Keeping logs helps.
Does home exercise work as well?
Interestingly, one study mentioned found that home-based programs could achieve similar improvements in walking distance compared to supervised ones. That's really important for people who can't easily access a formal program.
Education is also part of phase 2.
Yes, formal and informal sessions. Understanding the why behind the disease and treatments helps motivate people to stick with the changes.
And they track progress.
Continuously. with specific reevaluations midway and at the end, checking walking distance, risk factors, home exercise adherence, function, quality of life.
Then what? Phase 3.
That's maintenance. Continuing the exercise habit, maybe with less supervision, either at the facility or entirely on their own. Periodic check-ins are recommended.
So overall, are these PRPs effective?
The sources say yes, proven safe, beneficial, and cost-effective. They lead to those significant jumps in walking distance. 97% to 179% increases are mentioned. And they seem to help with sticking to risk factor changes and exercise long-term.
Okay, that's a lot of great information. Let's try to tie it all together using the case study provided in the sources, the patient JW.
Right, the 63-year-old woman. This helps make it concrete.
So JW has type 2 diabetes, PAD, causing claudication after just 2 blocks. She smokes, has high cholesterol and triglycerides, high blood pressure. She's obese. A common picture, unfortunately. Her goal, play tennis again.
We get some details: her meds, weak pulses, low ABI values confirming PAD, labs showing okay A1C today, but high triglycerides, low HDL, LDL needing treatment.
The sources then pose questions about her case. Let's use these to reinforce the key points for you, the listener. First up, smoking cessation meds for JW.
Based on the sources, you discuss options like bupropion or nicotine replacement therapy.
Okay. Next, she's confused about 2 of her potential PAD meds, clopidogrel versus silostazol. What's the difference explained in the sources?
Clopidogrel is mainly an antiplatelet drug to prevent heart attacks and strokes. It won't help her walking pain. Silostazol is specifically for improving claudication symptoms by dilating vessels, though it has some antiplatelet effects too. She could potentially be on both.
Good distinction. Now, she's on atorvastatin, a statin, and might be on clopidogrel. What was that potential interaction?
Atorvastatin might reduce the effectiveness of clopidogrel. So the sources suggest her doctor might consider switching her to a different statin like simvastatin or pravastatin to avoid that potential problem.
For reducing her overall risk of heart attack or stroke, especially thinking cost-effectively, what do the sources suggest?
Low-dose aspirin, 81 milligrams daily. More cost-effective than clopidogrel for this purpose generally.
Thinking about her diabetes, what were those 3 main microvascular complications again?
Nephropathy, kidneys, retinopathy, eyes, and neuropathy, nerves.
Initial treatment options for her actual PAD symptoms, the claudication.
Either a structured home walking program or enrollment in a formal PRP, plus dietary counseling to address all her other risk factors: weight, lipids, diabetes, blood pressure.
Her triglycerides are high. How might that be addressed?
ITGs are noted as a big risk factor in women. Low-carb diets might make them worse, so avoid those. Her doctor might cautiously consider adding niacin or a fibrate, but with careful monitoring.
Her blood pressure reading today was 1/300/887. Is she controlled?
The sources say you can't tell from one reading. Need an average over multiple visits, done properly. And adding a diuretic could boost her current ACE inhibitor medication.
And why is controlling your blood pressure so important? What are the benefits?
It slows down atherosclerosis, prevents that target organ damage, heart attack, kidney failure, stroke, and ultimately lowers her risk of complications and death.
Last question from the case study. JW finds treadmill walking painful and wants to just use the arm bike or stationary bike in rehab. Is that just as good for her claudication?
Based on the sources, you'd explain that while those other machines are great for overall fitness and heart health, walking is the specific activity that uses the calf muscles and is proven best for improving the claudication itself and increasing walking distance. The other machines are key for continuing to exercise after the walking part becomes too painful in a session.
That case really helps illustrate how you apply all these different pieces of information to a real person.
It does. It shows it's not just about treating the leg pain in isolation. It's about managing the whole systemic disease and all the contributing factors.
So let's wrap up this deep dive. The big picture. Atherosclerosis is a serious body-wide issue.
Yeah, driven largely by those 4 key modifiable risk factors: smoking, diabetes, dyslipidemia, and hypertension.
And aggressively managing these through both lifestyle changes and the right medications is absolutely critical.
And specifically for people with PAD, particularly with claudication, exercise emerges as this incredibly powerful tool.
Especially within structured programs like PRPs, which offer proven significant benefits, sometimes even better results than drugs or procedures for improving walking ability.
It's clear from digging into these sources just how much impact these interventions can have.
It really is, which leaves us, and you, with something to think about.
Given how effective lifestyle changes and programs like PRP can be,
How can individuals best work with their doctors, use the resources available, and really commit to making these sometimes difficult but potentially life-saving changes happen?